think I can start then. Good afternoon, everyone. Thank you for attending BioReperia Webinar today and for your interest in understanding how our Zebrafish platform can accelerate drug discovery and be used in precision medicine. So it's very nice to see you all here. So my name is Francielli and I'm the Customer Development Manager here at BioReperia. And today I'll be moderating this webinar. So please remember to mute yourself, and it will be very nice if you get to see some faces also in the videos. So if you have any questions, please write them in the chat and we'll be going through them in the end of this webinar. And we already have some questions that we got previously that will be also addressed in the end of this webinar. So this webinar is going to be recorded and will be after the event posted in our online channels. And you can expect around like 20-25 minutes presentation and follow it by questions. So once again, thank you for joining BioReperia article webinar today. And the paper that's going to be addressed was published in the beginning of this year by BioReperia and Linköping University. So since in May, we observed the World Ovarian Cancer Day, that was May 8th, we believe there is no better time to get updates on how the Zebrafish tumor xenograft models can potentially be used as a prognostic approach to epithelial ovarian cancer. So it's my honor to introduce our co-founder at BioReperia and CTO, Lasse Jensen, that will be the keynote speaker of today. So Lasse is an associate professor at Linköping University and is responsible for the Zebrafish facility. He is the inventor of the platform and has over 18 years of experience within the field of tumor xenograft models. Dr. Jensen also has outstanding experience in developing new disease models within the Zebrafish animal system, which are exploited in the company. Dr. Jensen is responsible for technical inventions and heads the automation program here at BioReperia. So please, Lasse.
Thank you very much.
Take the lead.
I will share the presentation here. I hope you see it. You see the presentation? Very good. Thank you very much. So indeed, as Franciella mentioned, I'm going to present our publication here. It was published earlier this year in NPJ Precision Oncology and has this title, Zebrafish tumor xenograft models, a prognostic approach to epithelial ovarian cancer. You see the authors here in the lower part of the slides. The first authors are associated with Linköping University Hospital, so they are gynecological surgeons and pathologists working at the hospital, and it's followed by several people here from BioReperia. So here in BioReperia, we really have a very strong collaboration with the hospital, Linköping University Hospital, as well as with the university. Several of the middle authors here from the university, and I am myself also both associated with the university and BioReperia. So what we have done in this paper is to analyze the behavior and response to treatment of tumor cells implanted in the zebrafish larvae. This is briefly what the process looks like. We take tumor cells isolated from a biopsy. I will go into this a bit in more detail later. Implant them subcutaneously in what is known as the perivitelline space in zebrafish larvae that are 2 days old at the time of implantation. We then either treat these tumor-bearing larvae with the treatments added to the water or co-inject the treatments. That was not done in this project. In this particular project, we added the drugs to the water. And we then analyze the effects of these drugs on the tumors over the course of 3 days. And you can see in this a fluorescent panel here, or a panel of fluorescent micrographs, what it looks like if a tumor implanted in the zebrafish embryo is not treated. 3 days later, it has really established as a small but primary tumor that is invading the surrounding tissues. If it's treated effectively, you can see that the tumor is shrinking and almost disappearing 3 days after implantation and treatment. Not only the primary tumor can be studied, we can also study the metastatic dissemination of the tumor cells in this model system. As you can see in the lower left, red tumor cells can be identified in the vasculature shown in green here 3 days after implantation in this primary metastatic region known as the caudal hematopoietic plexus. Far away from the primary tumor site, so it's hematogenous dissemination that is studied with this system. This was also used and evaluated in this paper. So the paper is on prognostics, which can be considered as a different approach compared to what has been done earlier, which is diagnostics. And usually when it comes to treatment planning, people, clinicians mainly, but also researchers, are thinking about in vitro diagnostics in order to subdivide patients into different groups, supporting the diagnosis such that a more accurate decision on treatment for this specific subgroup of patients can be delineated and applied. So this techniques within diagnostics include medical imaging, pathology assisted diagnostics, so pathology or histology, diagnostic biomarkers, for example, staining of pathological slides or looking at serum samples. It can be genomics to evaluate the mutations present in the tumor cells, or transcriptomics. All of these systems or these methodologies are used to subdivide a patient with, for example, epithelial ovarian cancer into different subgroups. Each subgroup can then be treated with a specific drug that has been shown in clinical trials to be more effective within this particular subgroup. That is diagnostics. Prognostics does not relate to subdividing patients prior to treatment. It instead looks at how are the patient faring, how long do they survive, or for how long do they resist progression in their disease. Methods within prognostics include also medical imaging and biomarkers. Now it's prognostic biomarkers, but it can also be demographics, for example, age or gender. It can also be smoking or alcohol use or other things that affect for how long the patients can survive with their disease. Prognostics are more closely associated with the efficacy of the treatment because if a treatment is efficacious, the patients survive longer, so they have better prognosis. We therefore propose that prognostics will play a stronger role. If you can have a more accurate prognosis of a patient treated with a certain drug, you will know whether that drug is efficacious or not, rather than subdividing patients into groups. It's not as precise in our idea is it's not as precise to determine which patient should be treated with which drug compared to predicting the prognostics of each individual patient on a certain treatment. So this paper is on prognostics, and you will see how it has helped us to hopefully in the future improve the treatment outcomes in this patient group. What we have done here is we've taken a broad group of patients, everyone with epithelial ovarian cancer. So there are several subgroups of patients based on these diagnostic principles that I just mentioned, but we have taken all of them as one group. We took either samples from the primary tumor or from metastasis. I'll go into this in a bit more detail later. Implanted these tumor cells into 2-day-old zebrafish, evaluated not 3 as shown here, but 2 different drugs, either carboplatin or paclitaxel. And after when the fish were 5 days old, so after 3 days of treatment, we evaluated the response to these 2 drugs. And then we saw whether the patients given these drugs had a long or a short progression-free survival. So we evaluate their prognosis, basically. First, before we did any treatments of a tumor-bearing zebrafish, we needed to understand if carboplatin and paclitaxel was tolerated by our model system. the 2 to 5 days old zebrafish. So we started treatment with different concentrations of carboplatin or paclitaxel at 2 days and looked at which doses were toxic. And we then evaluated the maximal tolerated dose, 10 micrograms per milliliter when it came to carboplatin, and we did not find a maximal tolerated dose of paclitaxel. And this may be because paclitaxel is not soluble at the doses shown above 10 micrograms per milliliter. So it crystallizes when added to the water. So the actual free concentration of paclitaxel is much lower, and that might be why we don't see a maximal tolerated dose. It's not soluble at a dose that will kill the fish. So it's basically infinite in this graph here. It's worth keeping in mind. We then looked with an epithelial ovarian cancer cell line implanted into the zebrafish at 2 days, whether these doses, either the maximally tolerated dose for carboplatin or a similar dose for paclitaxel, alternatively 2 lower doses, would be efficacious in reducing the primary tumor volume of these cells. And we saw that indeed both the submaximal and maximal dose of carboplatin were both effective at reducing the tumor volume, whereas paclitaxel did not reach statistical significance, but it was close, both at 2 micrograms per milliliter and 10 micrograms per milliliter. We then looked at metastasis and investigated whether either carboplatin or paclitaxel could reduce the metastatic dissemination. You can see the metastasized cells here in red. They're pointed to by yellow arrows. And you can appreciate that carboplatin, even at the highest doses here, does not reduce the amount of metastatic cells compared to the vehicle, whereas paclitaxel effectively reduced the metastatic dissemination, especially at the highest doses here at 30 micrograms per milliliter. However, because, as I showed before, that it was only borderline significant at 10 micrograms per milliliter and paclitaxel was well tolerated even at higher doses, we decided to go ahead with a higher dose, 30 micrograms per milliliter in the subsequent studies. But we kept carboplatin at 10 micrograms per milliliter because that was the maximal tolerated dose in the system. When it comes to the clinical study design, we first evaluated whether we could use cryopreserved tumor samples. It really facilitated the infrastructure, the clinical sampling, and the use in the zebrafish model. So comparing fresh and frozen or cryopreserved tissues, we saw that there was a significantly reduced viability of the cells obtained from cryopreserved specimens compared to if they were used directly from the operating room, but it was not a very large reduction in viability, and also more importantly, the size of the tumors, so the spontaneous regression of the tumors, was not significantly higher when we use cryopreserved material. So we decided to use cryopreserved material as it would give an equally good engraftment, although the viability of the cells was slightly lower. We then proceeded with this protocol and collected 83 tissues from 52 EOC patients or suspected EOC patients, epithelial ovarian cancer patients. We found that of these 83 tissues, 46 unfortunately did not allow us to isolate enough cells with our, at that time, protocols for tissue disruption. So we only were able to isolate cells from 37 of these 83 tissues, giving and not only isolate them but also implant the cells in the zebrafish, giving an implantation success of 45%. I will say that we have, since this study was done, optimized these protocols. We were not happy with the implantation success of 45%, and we now have significantly better implantation success. But this is what we could publish at this time. Of these 37 tissues, 10 unfortunately came from patients that through the pathology diagnosis was identified not to have epithelial ovarian cancer. They had a different type of cancer. So it was only 27 tissues from 27 epithelial ovarian cancer patients that were then included in the study. Among these, we saw that 19 tissues had a relatively modest spontaneous regression, meaning that they survived after implantation in the zebrafish embryo. Indeed, we had an engraftment success, which this is a measure of how well the grafts survive in the zebrafish, of 70%. So we could evaluate treatment outcomes from 19 tissues and 17 UC patients in total. From 4 of these patients, unfortunately, we were not able to obtain information regarding their survival or whether they progressed in their disease. These patients were not from this region. They came from a different region, but was treated surgically in Linköping. And because of this, we were not able to obtain the journals from these patients and could therefore not follow their progression over time. But this could be done for 13 patients, 4 of which were treated with neoadjuvant therapy and 9 with adjuvant therapy. We could evaluate metastasis from a bit more patients than this. First, regarding the tumor implantation, what we did was we took samples either from the primary tumor in the ovary or from omental metastatic lesions. We digested these tumor tissues with our proprietary mix of agents that digest the tissue, and we then labeled these cells with a red fluorescent dye that sits in the plasma membrane. It's called DII. The plasma membrane becomes red fluorescent. We then implanted these cells into the zebrafish larvae and treated for 3 days and evaluated the change in size. And we observed that without treatment, so in this figure here, we have just evaluated the size change in the control group without treatment. And as you can appreciate here, most of these samples, they engrafted well. They regressed less than the cutoff here of 20%. So there was enough tumor left at 3 days to be able to evaluate an augmented reduction in tumor size due to the treatments. And that's how we define a successful engraftment. There was no difference, as you can see, in the engraftment of primary tumors compared to samples taken from metastasis. So they survived equally well in the zebrafish. Interestingly, also when it comes to metastatic dissemination here, you can see that tumor cells from the primary tumor had very similar metastatic dissemination in 2 patients here compared to tumor cells isolated from the metastasis or metastatic lesions, whereas there were 2 patients that had significantly more metastatic dissemination in the zebrafish model from the metastatic lesions, which would be expected, of course, that those cells are more metastatic compared to the primary tumor cells. But this was only the case for 2 or 4 patients. We then evaluated metastasis in a very similar manner. We disrupted the tissue, labeled the cells with red fluorescence, implanted them in the zebrafish, and looked at the amount of metastasized cells 3 days later. And here is another representation of what this could look like. Again, in untreated control zebrafish, we looked at whether the number of metastasized cells in the zebrafish model could predict anything regarding the prognosis of the patients or which stage cancer they presented with. This comes from the pathology-assisted diagnosis. And indeed, we saw that if we applied a cutoff level of 6 metastasized cells here, we could find 12 of 15 patients that had below this cutoff of 6 metastasized cells on average, had a very long progression-free survival. So we could, with 80% sensitivity, predict that these patients would have a long progression-free survival already at the time of surgery. Whereas among the 4 patients that had short progression-free survival, 3 of them, or 75%, had more than cut off, more than 6 metastasized cells in the ZTX model on average. So again, we could predict with 75% sensitivity that these 4 patients would have poor progression-free survival. Also, when it comes to staging, you can clearly see that patients that group as stage 1 or 2 ovarian cancer, they have much fewer metastasized cells, most of them, compared to the patients that are in stage 3 cancer, most of which had many more metastasized cells in the CTX model. So it's also a very good way of separating stage 1, 2 or stage 3 cancer patients. We then looked at treatment efficacy, both with carboplatin and paclitaxel, and we could observe that among the 4 patients where we in the ZTX model saw they responded to carboplatin, all of those 4 patients also had a long progression-free survival. So if we were to say already based on this treatment outcome in the ZTX model that these patients would have a good prognosis, we would be right in all 4 of these 4 cases. Also, the 2 patients that had a short progression-free survival, both of these patients did not respond to carboplatin in the ZTX model. Paclitaxel, given at a very high dose, 30 micrograms per milliliter, was effective for all 4 patients, but indeed 3 of these patients also had a long progression-free survival. Only one had a short progression-free survival, the same one that didn't respond to carboplatin over here. So we think that we perhaps gave too much paclitaxel, and we therefore feel that the carboplatin data is more accurate in terms of predicting the prognosis of these patients. So the conclusions from our study is you can actually create ZTX predict models from your patients based on cryopreserved samples. When you create ZTX predict models from primary tumors, these would behave similarly as if you create them from cells obtained from metastatic lesions. The metastatic dissemination correlates very well with both tumor stage and time to progression, at least as shown here in epithelial ovarian cancer. And evaluating the efficacy of the standard of care therapy in ZTX predict models also shows whether this standard of care would give a better prognosis to the patients or not. So it has a prognostic significance. Thank you very much, and I hope that you will continue the discussions on how ZTX predict models can possibly help you in either designing your clinical trials or if you're from a hospital, treat your patients more effectively. The model is used in both clinical studies, but also in some cases in clinical practice today. It's CE marked and IVD approved, so it can be rolled out in Europe at least for routine treatment planning purposes. So we'll keep that in mind, and I hope that you will hit me with some questions and consider using ZTX models in the future.
Thank you so much, Lasse. So as Lasse was saying, please just like send your questions in the key questions and answers in the button there. Or also we have some questions that we got already, Lasse, from previously. So one person was saying like only 37 out of 83 tumor biopsies were successfully implanted into the zebrafish. Is that a problem seen in all tumor indications in regards to clinical biopsies? That was one question that we got.
Yes, that's an excellent question. And indeed, we often see much better implantation success in other indications. The 45% implantation success in this study was mainly due to this being the first study we ever conducted on patient samples. Our protocols in the beginning were not very good. Most of the patients we didn't succeed with came from these the first half of the cohort we analyzed, and we did not succeed with very many. The study started in 2017, I think. So it has been a long time going, as you can imagine, since we had at least 2 years follow-up on each of these patients. So today, our protocols for isolating tumor cells from tumor tissues are much better. Within the last 20 patients in this epithelial ovarian cancer study, I think we succeeded with at least 15, if not more. And epithelial ovarian cancer is the hardest diagnosis we have worked with. In other diagnoses, we succeed with something closer to 90% of the patient samples we get, at least if we get large enough samples. If we get very, very small samples, then it might be difficult. But of course, the number of cells you can get from a sample correlates with the size of the sample. So yeah.
Yes, good, thank you. Another one was like, how translatable is the zebrafish model compared to rodents in the clinic?
Yes, very good question. There has been large studies on rodent PDX models and how well treatment outcomes in those models correspond to in the actual patients. For example, I think it was Champions Oncology that published a study with 1,000 PDX models or something like that, very large study, showing that it was just over 80% correlation. So in more than 8 out of 10 patients, if you saw a treatment outcome, a positive treatment outcome or a negative treatment outcome in the rodent PDX models, you would see the same outcome in the patient to that drug. In the studies we have done, they're not so big, but we have done this study, and we have done a study in non-small cell lung cancer that was published. We've done a study in urinary bladder cancer, 2 studies, one that's published and one that is being submitted very soon. And we have also evaluated this in colorectal cancer and a few other cancer types. And we see overall somewhere between 80 to 90% predictive accuracy in these diagnoses, based on perhaps 150 to 200 patients if you group all of these diagnoses. So again, not as many patients yet as in the Champions Oncology study, but still quite a few patients, and we see very similar predictability in terms of predicting the treatment outcome as in the rodent models. We've also directly compared head-to-head the same patient sample injected in a rodent and in a zebrafish treated with the same drug, and looked at the treatment outcome either in the rodent or the zebrafish and compared those with each other. And we see the same treatment outcome. This was published in the paper I mentioned on non-small cell lung cancer, where we actually in 16 of 17 direct head-to-head comparisons saw exactly the same treatment outcome. So we get the same treatment outcome as in a rodent PDX model, but in 3 days and with not quite the same cost, to say it lightly. Yeah.
Great. And another question is like, is the injection site of the zebrafish always in the same place as the ovarian cancer, or it depends on the tumor indication?
We always implant the tumors in the same place. We do not implant them in the same organ as what is affected in the patient. So for this epithelial ovarian cancer project, we did not implant the tumors in the ovaries. We always implant the tumors in a subcutaneous area known as the perivitelline space. It's similar to subcutaneous implantation in a mouse, and it doesn't matter which cancer, we always implant any cancer in this area. So it's not an autotropic model system, unfortunately. Of course, you can in some cases implant tumors in the same organ. I know some people studying CNS tumors, brain tumors, that implant them into the brain in the zebrafish. But most organs in the zebrafish are not well enough developed at 2 days post-fertilization to actually put the cells in that organ. So it's only possible for a few organs, and therefore we decided to do the same for all cancers and implant them subcutaneously.
Good. So we have one more question, the last one, but I think you already talked a little bit. Is the Zebrafish platform already in use into the clinical practice?
Yes, it is. It is very much used. There's not so much evidence for the benefit of acting on the results. So it's mainly used to plan clinical trials, for example. It's used to understand in the future whether we should use a different type of treatment for this patient group, but not acting directly here and now. But we expect to get there very soon, where clinicians will actually have the nerve to act for a given patient here and now on the data from the ZTX model. It is allowed for them to do this, so it is approved as a treatment planning tool, but clinicians are careful. They do not take as much risk, and they feel that we need larger clinical studies before they feel comfortable with this, and they are ongoing, and they will very soon be ready, especially for some patient groups. We expect perhaps already this year to start acting on results for patients with liver metastasis, where we have shown that we have excellent engraftment, both implantation and engraftment rate. Almost all of the patients in a clinical study could be engrafted, and we could evaluate the treatment outcome. So very soon we expect to roll that out into clinical practice, and hopefully also for epithelial ovarian cancer in the future.
Great. So thank you so much, Lasse, for a very interesting and great presentation today. And I hope you all got your questions answered. But of course, if you think or have anything in mind after this webinar, please do not hesitate on contacting us. So we are very happy to set up a meeting with you to discuss your specific projects or any questions that you might have. So thank you again very much for attending today, and we wish you all a great evening. Thank you so much.
Thank you.
And bye-bye. Thank you, Lasse.
Bye.